So, testicular masses and penile pathologies. Lesions of the testes can be congenital, inflammatory, or neoplastic. The most relevant pathological condition is cryptorchidism, which is linked with testicular cancer. It's a failure of testicular descent and affects about 1% of males. It occurs more frequently on the right than the left, but is bilateral in 25% of cases. The pathogenesis is not well understood, but there are probably hormonal and or testicular or mechanical abnormalities. This leads to atrophic testes. The clinical importance is twofold. One outcome is infertility, and the other is the possibility to develop testicular tumors. The increased risk of malignancy is 10 times that of the general population. Their treatment is orchipexy, which may help prevent atrophy, but it's controversial whether it actually decreases the risk of malignancy. Probably not. Other causes of testicular atrophy are chronic ischemia, inflammation or trauma, hypopituitarism, excess of female sex hormones, such as intrahepatic administration when there is treatment of refractory prostate cancer, or in cirrhosis. We have also malnutrition, irradiation, and chemotherapy. Inflammatory lesions of the testes. The inflammatory lesions of the testes are relatively infrequent. They usually involve the epididymitis first and are mostly related to sexually transmitted disease. There are also forms of non-specific epididymitis and orchitis, especially due to bacterial and non-bacterial urinary tract infections. The main symptoms are swelling, tenderness, and pain. The other inflammatory lesions are due to mumps. 20% of adult males with inflammatory lesions of the testes have this viral infection. They have chronic inflammatory infiltrates and may risk atrophy and sterility. Tuberculosis also used to be a relatively frequent cause, leading to granulomatous inflammation and caseating necrosis. Autoimmune granulomatous orchitis has a differential diagnosis with testicular cancer. It is histologically difficult because it has similarities to lymphoma. Testicular neoplasms. They are the most important cause of painless enlargement in the testes. The incidence is 2 over 10,000 males. It occurs more frequently in blacks and among siblings. Peak incidence is 15 to 34 years. There are also some peculiar geographic differences. In Finland, there are fewer cases than in Sweden, but when people from Finland emigrate to Sweden, they develop the same risk as Sweden's. 95% are malignant. It accounts for only 1 to 2% of all cancers in men, and is the most common tumor between 15 and 35 years. The most common solid tumor between 15 and 35 years. There is an estimated 8,450 new cases in the United States per year, with only 350 deaths. This is a reflection in the improvement we have made with available treatments. It's considered a curable tumor. Seminomas are the most frequent type and occur more frequently in age 25-45 years, whereas non-seminomatous germ cell tumors affect the 15-30 year age group. Regarding etiology, there is nothing particularly relevant. Infection may play a role and possibly trauma, although it's more likely that trauma leads to testicular examination, which leads to incidental diagnosis of cancer. Prenatal factors, prenatal factors include miscarriage, maternal nausea, and C-section. Prenatal factors including miscarriage, neonatal nausea, and C-section are controversial associations. The only significant risk factor is cryptorchidism. Orchipexy prior to puberty probably somewhat lowers the risk, although the risk still occurs even for the contralateral testicle. The mechanism of this is unknown. Testicular dysgenesis, XXY Klinefelter syndrome, is also linked to testicular tumors, probably also intrauterine exposure to pesticides, as well as a history of testicular cancer, so which increases the risk of tumor development in the contralateral testicle. 95% of cases arise from germ cells. A genetic mutation of the short arm of chromosome 12 is a common finding, and thus a marker for this type of tumor. Germ cell tumors may also arise in other parts of the body, such as retoperitoneum, mediastinum, sella turcica. Most of these tumors are associated with an intratubular germ cell neoplasm, which is considered the first step in the development of germ cell tumors. Less frequently do tumors arise from Sertoli or Leydig cells, and most often they are benign. The third type of neoplasm that is observed relatively frequently in the testes is a primary lymphoma of the testes in men over than 60 years old. So the main types of neoplasms occurring in the testes are intratubular germ cell tumors, seminoma. This is a seminoma with syncytial trophoblast cells, spermatocytic seminoma, embryonal carcinoma, endometrial sinus tumor, it is yolk sac tumor, choriocarcinoma, and teratoma. These are all germ cell tumors. Then we have sex cord tumors, which include Leydig cell tumor, benign and malignant, Sertoli cell tumor, benign and malignant, granulosa cell tumor, and fibromatecoma. Regarding the percentages of these tumor types, they can be pure or mixed. 40% demonstrate one histologic pattern. Seminomas are the most common. 30%, followed by embryonal carcinoma. Yolk cell tumors, choriocarcinomas, and teratomas are almost never a single histologic pattern. The majority of tumors, 60%, instead demonstrates multiple histologic patterns, embryonal carcinoma plus teratoma, choriocarcinoma, with seminomas being one of the components. This is the hierarchy of differentiation, but not in terms of malignancy. The germ cell seminoma is the most benign and is very sensitive to therapy. The teratoma is very rare and is most often immature. Malignant teratoma is an embryonal tumor with features of malignancy at the histological level. Below and to the left is normal testicular tissue. Above and to the right is a malignant intratubular germ cell tumor. The tubule is filled with large atypical cells, and there is an increased thickness of the walls of the tubules, as well as an inflammatory infiltrate. The intratubular tumor is usually undifferentiated. Here is another image of an intratubular germ cell lesion. You can see the atypia of these cells, of all these cells, with high mitotic rates. Mitosis is usually high in the spermatogony, but these cells are atypical because they are not differentiated into spermatids or spermicides or spermatocytes. So, spermatogony are atypical. Macroscopically, the seminoma is described as a fleshy pink salmon in appearance. This is the microscopic aspect of the seminoma. Seminomas are large, monotonous, undifferentiated cells with a big nucleolus, large cytoplasm, and typically full of glycogen. It's also typically associated with a dense inflammatory infiltrate. They have a large nucleolus. Sometimes these cells are accompanied by other multinucleated cells. We refer to this as syncytial trophoblastic. In this case, it is in this case that we can have an elevated beta HCG. Here we see the seminoma and syncytial trophoblast. The other more aggressive form of germ cell tumor is the embryonal carcinoma. It occurs as a poor form in 10% of cases and is mixed 90% of the time. The peak incidence is around 30 years old, 10 years before seminomas. They have different patterns of growth that can be solid, syncytial, papillary, or pseudoglandular. The cells are very large, epithelioid in appearance and anaplastic. Macroscopically, they have red to brown areas and may frequently have areas of hemorrhage and necrosis. For a hemorrhagic tumor, you may also suspect choriocarcinoma. Microscopically, the cells are very atypical. You can have trabecular syncytial growth, large cells with a big nucleus, and pink cytoplasm. Embryonal carcinomas have very irregular nuclei. When you have a papillary growth, you may also think about a yolk sac tumor. It's very important to evaluate markers like AFP, beta ECG, and LDH before treatment. Here you can see the difference between the seminoma cells and embryonal carcinoma cells. They have a different organization and different cellular characteristics. One of the markers we use for identifying embryonal carcinoma is CD30, which can also be evaluated using the sera of these patients. Remember, this is also a marker for Hodgkin lymphoma. Embryonal carcinoma occurs more frequently than the seminoma. And spreads through the lymphatic system or blood vessels. So you can actually find tumor cells of embryonal carcinoma inside of lymphatic vessels, inside the spermatic cord. Yolk sac tumors usually occur just in very young boys, around 3 years of age, and histologically they have quite characteristic features. One of the morphologic characteristics is the presence of the glomeruloid body. The specific marker for this lesion is alpha-fetoprotein. This is the Schiller-Duval body, which is a tumor that has a fibrovascular core and is reminiscent of a peculiar structure in the extraembryonic trophoderm in the early phase of embryogenesis. These tumors are cystic with very different patterns of glandular, papillary complex texture and architecture, and also perform an alpha-fetoprotein histological test on this tissue. Choriocarcinoma occurs in the young and is very rare and aggressive tumor. It's always a mixed type tumor with teratoma and other tumor including seminoma. Histologically, it's malignant cyto and syncytiotrophoblasts without villous formation, usually very hemorrhagic and necrotic. These tumors do not form vessels or stroma. They exist like islands within the tissue and invade and destroy vessels very rapidly. Then we have the teratoma or teratocarcinoma. Its features include chondroid, fleshy white, and apparently solid areas. It has different components. One is embryonal carcinoma hemorrhagic and the other teratoma. You can see glands and immature stroma. Then we have the dermoid cyst, which is the most frequent teratoma in the ovary. Teratoma, malignant teratoma, and this germinoma are the equivalent of the seminoma in the ovary, and they are comparatively very rare. Clinical course. Tumor markers are very important as well as the presence or not of metastasis, and treatment success depends on histology and stage. Usually in seminomas we only have involvement of regional lymph nodes. Seminoma is the most sensitive to chemoradiotherapy. Differential diagnosis. Epididymitis is the most common. There is also spermatocele, epididymal cyst, varicocele, testicular torsion, and hernia. Diagnosis. Ultrasound is highly specific. We have hypoechoic lesions, but diagnosis is made at radical orchiectomy. Tumor markers are important. We have two main classes. One is called oncofetal substance and includes AFP and ECG. Then we have cellular enzymes, LDH, no specific measure of tumor burden, and PLAP, which is placental alkaline phosphatase produced by seminomas and embryonal carcinoma. AFP levels are elevated 50-70% in NSGCT, non-seminomatous germ cell tumors, and the half-life is of 7 days. It's also important to verify the levels of these markers after orchiectomy, because if the levels are still elevated, there is probably residual disease in the body. The normal value of AFP is below 16 nanograms per milliliter, and it can be raised not only in poor embryonal carcinoma, but also teratocarcinoma, yolk sac tumors, and combined tumors. It's not raised in pure choriocarcinoma and pure seminoma. HCG levels are elevated in 40-60% of tumors and has a half-life of 24-36 hours. Its normal value is less than 1 nanogram per milliliter. It's raised in 100% of choriocarcinomas, 60% of embryonal carcinomas, 55% of teratocarcinomas, 25% of yolk cell tumors, and 7% of seminomas. The degree of marker elevation is directly proportional to the tumor burden. Treatment. Treatment varies depending on the type of cancer and the stage. There are also fertility issues to consider. 25% have fertility issues at the time of disease presentation, but this may be to an atrophy of the tubules before the onset of carcinoma. These patients have high concentrations of anti-sperm antibodies compared with the general population. 50% are subfertile post-orchidectomy. Immunoprofiling, sometimes the morphological features are not sufficient to make a diagnosis of tumor type, so we have to do immunoprofiling. Utilize different immunohistochemical markers that help with identification. OCT4, for example, is a transcription factor that is expressed in stem cells. OCT4 is found in a seminoma as c-KIT and alkaline phosphatase. So we have that different markers here: CT4, c-KIT, PLAP, D240, CAM52, and AE1, AE3, CD30, AFP, GlyPcan3. Part to the penis. The lesions that can involve this organ include malformations, inflammatory lesions, and neoplasms. Regarding malformations, one of the most important is an abnormal location of the urethral orifice along the penile shaft. Hypospadias involve the ventral aspect and are the most common, 1 over 300 live male births. We can also have epispadias, which are less frequent and occur on the dorsal aspect. This malformation may be associated with other abnormalities such as inguinal hernias and cryptorchidism, undescended testes, and the clinical consequences include the constriction of the orifice, urinary tract obstructions and infections, and impaired reproductive function, so they must be surgically corrected. Regarding inflammatory lesions of the penis, most of them are from sexually transmitted diseases. Ballantitis is an inflammation of the glans and prepuce and is associated with poor local hygiene in uncircumcised men. The distal penis becomes red, swollen, and tender, with or without a purulent discharge. Phimosis is when the prepuce cannot be easily retracted over the glans, may be congenital, and is usually associated with balanopostitis and scarring. Paraphimosis can result in urethral constriction. Fungal infections such as candidiasis can occur, especially in diabetics, and may lead to erosive, painful, and pruritic lesions that may involve the entire male external genitalia. We can also have neoplasms that affect the penis. Squamous cell carcinoma is uncommon, representing less than 1% of cancers in US men. There is a higher prevalence in uncircumscribed men, between 40 and 70. It's thought to be related to poor hygiene, smegma, human papillomavirus 16 and 18. It typically starts as a carcinoma in situ first, then progresses to invasive squamous cell carcinoma. Remember, circumcision is protective. HPV is present in 50% of these tumors, and lichen sclerotrophicus is also a cause. It's not correlated to other STDs like herpes and syphilis. This is a picture of lichen sclerotrophicus. There is hyperkeratosis, atrophy of the epithelium. The chorion is infiltrated by lymphocytes and it has hyalized. So there is atrophy and sclerosis. This is a relatively frequent lesion in the penis. The clinical course is usually of squamous cell carcinoma is usually indolent, locally invasive, inguinal lymph nodes being the site of metastasis. The 5-year overall survival is 70% without lymph node metastasis and 27% with metastasis. Histological variance, squamous cell carcinoma accounts for 70%. Affects people on average at 58 years old, is G2 keratinizing with penile intraepithelial neoplasia frequently associated. A more aggressive variant is the basaloid type, which is usually associated to HPV. Also associated to HPV is the condylomatous type, usually a G3. Verrucous is a variant of squamous cell carcinoma that rarely metastasizes and is not associated to HPV, usually G1. This can also occur in the oral cavity and skin. They can be very large tumors but rarely metastasize to the lymph nodes. Finally, there is papillary, which is usually a G2. Lesions involving the scrotum. Squamous cell carcinoma of the scrotum were the first tumors linked to the workplace. These tumors were linked to exposure to a chemical substance and were specifically found in chimney sweeps. Sexually transmitted diseases. The following are the most relevant pathogens affecting the penis. The one historically linked to cancer is HPV. The coilocyte is associated to the HPV infection. Then you have chlamydia, which are intracellular pathogens and form a type of granuloma. Neisseria causes epididymitis and requires culture for diagnosis. Syphilis is not so frequent but is making a comeback. You have to look for treponema in a smear. This can give rise to a secondary syphilis, which causes generalized lymphadenopathy, rash, and condylomatous type lesions. Finally, this can evolve to tertiary syphilis, which can cause cardiovascular disease, neurosyphilis, and the development of gummas in bone, skin, and mucous membranes. You also have herpes simplex and the granuloma inguinale caused by Calymatobacterium donovani. The test for syphilis now is the VDRL test. It's not done routinely and may yield false positives in the presence of SLE, lepromatous leprosis, pregnancy, and antiphospholipid syndrome.